Hello. Our names are Beza,
Zyra,
and Josie, and we are here to talk to you all about pharmacological pain relief for labor. Sedatives. They relieve anxiety and induce sleep. They're also given to augment analgesics and reduce nausea when an opioid is used. Barbiturates. Secobarbital sodium causes respiratory and vasomotor depression, affecting the woman and her fetus. Thus, it should be avoided if birth is anticipated within 12 to 24 hours. Phenothiazine does not relieve pain and has been proved to impair the analgesic efficiency of opioids. Metoclopramide, an antiemetic, has been found to potentiate the effects of analgesics, making it the preferred medication in comparison to promethazine. Benzodiazepines enhances pain relief and reduces nausea and vomiting, but has a major disadvantage because it disrupts thermoregulation in newborns, making them less able to maintain body temperature. Flumazenil, a specific benzodiazepine antagonist, which effectively reverses benzodiazepine-induced sedation and respiratory depression. Analgesia and anesthesia. Analgesia alleviates the sensation of pain or the raising of the threshold for pain perception without the loss of consciousness. Anesthesia abolishes pain perception by interrupting the nerve impulse to the brain that may be partial or complete. It ultimately provides adequate analgesic or anesthetic pain relief to women without increasing maternal or fetal risk or affecting the progress of labor. The type of anesthetic is determined in part by the stage of labor and the method of birth planned. The go-to method of analgesia when women are in labor is the epidural, which is classified as a regional analgesia. It can be administered via IV or IM. Opioids provide sedation and euphoria, but their analgesic effects in labor is limited. The pain relief provided is incomplete, temporary, and is more effective in the earlier part of active labor. Opioid narcotic agonist analgesic. An agonist is an agent that stimulates a receptor, while an antagonist is an agent that blocks a receptor. The types used in obstetrics is hydromorphone, fentanyl, sufentanil citrate, and morphine. They stimulate the major opioid receptors, mu and kappa. They create a feeling of well-being or euphoria and enhances a woman's ability to rest between contractions. Opioids can inhibit uterine contractions. Meperidine hydromorphone. Despite the analgesic effects, other medications have fewer adverse effects because they have an active metabolite that crosses the placenta and causes prolonged neonatal sedation and neurobehavioral changes. Fentanyl citrate and sufentanil citrate are potent short-acting opioid agonist analgesics. Fentanyl takes 1 minute to cross the placenta via IV. Its disadvantages is the frequent dosing required due to their short duration of action. Sufentanil use is increasing because it has more potent analgesic action when administered via epidural, which means less sufentanil crosses the placenta, resulting in reduced fetal exposure. Opioid narcotic agonist antagonist analgesics. Higher dosages do not produce additional risk of respiratory depression. Nubain provides adequate analgesia without causing significant respiratory depression in the mother or the newborn. Opioid agonist-antagonist analgesics are used more often during labor than opioid agonist analgesic. They are not suitable for women with opioid dependency because antagonist activity could precipitate withdrawal symptoms in both mother and newborn. Opioid narcotic antagonists. Hydromorphone, fentanyl can cause excessive CNS depression in the mother and the newborn or both. Lower doses of opioids IV has reduced the incidence and severity of opioid-induced CNS depression. Naloxone reverses CNS depression effects such as respiratory depression. Naloxone cannot reverse the effects of norepinephrine, which is an active metabolite, or meperidine. Antagonist counters the effects of stress-induced levels of endorphins, which is especially effective if labor is more rapid than expected and birth occurs when the opioid is at its peak effect. Women using the opioid analgesic pain will return once she administers opioid antagonists.
Analgesia reduces pain and decreases some motor functions, whereas anesthesia completely prevents pain and inhibits motor functions. Both analgesia and anesthesia are chemically related to cocaine, Medication in this family typically have suffixes ending with "-cane", such as lidocaine, chloroquine, and many more. Some common signs and symptoms of allergic reactions are hypotension or respiratory depression. Epinephrine, antihistamines, and oxygen could be administered to reverse the effects. Local infiltrations are typically used for when episiotomies are being performed to help ease the childbirth process, or if the tear has already occurred, local infiltration could be used during suturing processes. Local infiltrations can only be used for those who did not receive regional anesthesia. Epinephrine is often added into the solution prior to injection to help localize the bleeding and help with blood vessel constriction. Pudendal nerve blocks is another type of nerve block which can be used during the second stage of labor, which is when the woman is about 10 centimeters dilated and ready to push. Pudendal nerve blocks are useful during vacuum or forceps usage to help ease with the birthing process. It helps relieve pain in the vagina, vulva, and perineum. It is considerably safe to use, but with the increased public choice of using epidural, pudendal nerve blocks usage is a contraindication with epidurals. Pudendal nerve blocks have approximately 2 to 10 minute onset, lasting for 1 hour, therefore should be used just before vacuum or forceps is being performed. On the screen here, there is a picture of where the pudendal nerve block is typically injected. The main con to this approach is that the mother may have diminished abilities to bear down for this injection to be administered. Spinal anesthesia. It is injected in the 3rd, 4th, or 5th lumbar space into the subarachnoid space. The solution mixes with the CSF and causes complete blockage of motor function depending on where the injection was done. Spinal anesthesia is used for C-sections, which causes loss of motor function from the nipple downwards. We want to use spinal anesthesia for vaginal birth. We want to decrease motor functions from the hips, which is about T10 downwards. Spinal anesthesia for cesarean births. The woman should be placed in a side-lying position with the back curved into a C formation. This helps widen the intervertebral space, which helps facilitate the insertion of the spinal needle. If the woman is having a vaginal delivery, she should be positioned sitting upright post-injection to allow the solution to flow downwards from T10 to the toes. Or, if she's having a cesarean birth, she should be in a supine position with the head and shoulders slightly elevated to obtain T6 downwards freezing. We want to ensure supine hypotension does not occur, so we have to place a wedge underneath the hips to decrease the pressure from the woman lying on her back. Spinal anesthesia takes about 5 to 10 minutes to be effective and can last up to 3 hours. It is important for the healthcare providers to monitor fluid balance and have readily available IV fluids to be administered if the patient becomes hypotensive, caused by sympathetic blockage, which is a vasodilation in the lower extremities. We have to ensure when administering bolus IV fluids, dextrose is not included because that can cause neonatal hypoglycemia. Healthcare providers should also monitor for changes in breath patterns and placental function after administration of anesthetics. Fetal and maternal heart rate should be monitored every 5 to 10 minutes. During vaginal deliveries, we have to instruct the mother to bear down as she can no longer feel her contractions. Disadvantage of spinal anesthesia are hypotension and respiratory depression. Even though oxygen saturations may remain normal, mother may want a vaginal delivery but end up having a C-section performed. This can cause mother dissatisfaction with the delivery process. In a severe case, CPR may be performed from respiratory depression or allergic reaction. There could be an increased risk for bladder and uterine atony, increasing chance for postpartum hemorrhage, and women may experience post-dural puncture headache. But if not all cons, some pros are that women remain present during her delivery process. She can focus more on the delivery and less on the pain. There are a decrease of fetal hypoxia, and maternal blood pressure can be maintained within a normal range. Epidural. This is the most common anesthetic used for labor and delivery. It is injected within the 4th and 5th lumbar vertebrae. It is made up of local anesthesia and opioids such as fentanyl. Use of both local anesthesia and opioid reduces the dose of anesthetic requirement. This way we can preserve a greater degree of motor function. Steps to administer epidural. A large bore needle is inserted into the epidural space. The catheter is threaded through the needle until the tips rest on the epidural space. The needle is then removed and the catheter is kept in place, and a small amount of the medication is called the test dose is injected to ensure the catheter has not been displaced or misplaced. It can also be a way for us to check and see if the patient will have an allergic reaction to the medication. Obese patients have a harder time landmarking epidural sites as it may be harder for them to get into the correct position. Regional anesthesia can provide enough pain relief for an obese patient. It is said to be safer for an obese patient to receive epidural versus general anesthesia. Continuous epidural perfusion is commonly used as an option to help the woman feel in charge of her pain management, and studies have shown that with the continuous epidural pump, it actually decreases the amount of epidural being used compared to manually being injected. There are several pros to using epidurals as it keeps the woman alert and oriented towards her laboring process. It allows her to be more comfortable and relaxed. Airway remains patent and there are mild motor paralysis, little or no delay in gastric emptying, and less fetal complications. With pros, there are always cons to medication usage. There are increased labor time, which can cause malposition of the fetus, and increase the need for forceps and vacuum use. Increased need for oxytocin use. There are limited ability to ambulate. Dizziness from the sedation can occur. Orthostatic hypotension might happen from epidural use. CNS effects from the epidural being administered into the blood vessel accidentally. Excessive amount of local anesthetic could be administered. Fever may occur. Pruritus. Epidural may just not work for everyone. Epidural being administered too high up into the spinal can cause respiratory depression.
A post-dural puncture headache, or also known as PDPH or a spinal headache, is a headache as a result of cerebrospinal fluid or CSF leakage from the inadvertent puncture of the dura mater, which is the membranous covering of the spinal cord, from a spinal block. Postural changes cause the diminished volume of CSF to exert traction on the pain-sensitive CNS structures. The upright position triggers and intensifies a headache, whereas the supine position provides relief. Conservative management includes oral analgesics and methylxanthines like caffeine and theophylline. Methylxanthines cause constriction of cerebral blood vessels and may provide symptomatic relief. An epidural blood patch is the most rapid, reliable, and beneficial relief measure, and it is remarkably effective and nearly complication-free. 10 to 20 milliliters of the woman's blood is extracted from her body and is slowly injected into the lumbar epidural space that creates a clot to patch the tear or hole in the dura mater around the spinal cord. It is only considered when the headache is very debilitating and conservative management fails. The woman should be observed for alterations of her vital signs, pallor and clammy skin, and leakage of CSF for 1 to 2 hours after the blood patch. If complications occur, the woman can resume normal activity, but should be instructed to avoid coughing or straining on the first day. Combined spinal epidural analgesia is an increasingly popular approach that can be used to block pain transmission without compromising motor ability. Opioid receptors are highly concentrated along the pain pathway in the spinal cord, brainstem, and thalamus. Therefore, only a small amount of opioid agonist analgesic is needed intrathecally to produce long-lasting relief. Common adverse effects include pruritus, urinary retention, immediate or delayed respiratory depression, and nausea. Naloxone may be given IV to manage these side effects without it affecting the degree of analgesic effects. Close assessment of fetal heart rate is needed since combined spinal epidural analgesia is related to greater incidence of fetal heart rate abnormalities compared to epidural analgesic alone. Epidural and intrathecal spinal opioids are opioids that are administered in this manner, and they do not cause maternal hypotension or affect the woman's vital signs. The woman feels her contractions, but not the pain. Her ability to bear down during the second stage of labor is preserved because of the pushing reflex is not lost, and motor power remains intact. Examples of commonly used opioids include fentanyl and sufentanil, which are short-acting opioids, and morphine. Short-acting opioids are used for multiparous women, while morphine is used for nulliparous women or for women with a history of long labor. For most women, intrathecal opioids do not produce a strong enough analgesic effect, therefore are usually given in combination with local anesthetic, for example, bupivacaine. Women who receive morphine epidurally after a C-section are able to ambulate sooner than women who do not. Women who are in need of analgesics for breakthrough pain within the first 24 hours are usually given NSAIDs rather than a narcotic. Antiemetics, antipuretics, and opioid antagonists are used to relieve opioids' adverse effects. Contraindications to subarachnoid and epidural blocks include active and anticipated maternal hemorrhaging, significant maternal hypotension, coagulopathy, infection at or near the injection site, increased intracranial pressure caused by a mass lesion, allergy to an anesthetic drug, maternal refusal or inability to assist with insertion, and some types of maternal cardiac conditions. Back tattoos are not necessarily contraindicated, but should be avoided since there is a possibility that the epidural may not be effective. Epidural block effects on the newborn. Analgesia or anesthetic used during birth have little to no lasting effect on the physiological status of the newborn, nor later development of the child's mental and neurological status. Nitrous oxide for analgesia is administered as Entonox, which is a 50-50 oxygen and nitrous oxide mixture. It is a CNS depressant, which alters the pain stimuli, resulting in decreased perception of stimuli. Can be used during the first or second stages of labor and can be used in combination with pharmacological and pharmacological measures for pain relief. It is self-administered by the woman with a face mask or a mouthpiece. Loss of consciousness is more likely to occur when used in conjunction with opioids. It does not depress the uterine contractions or cause adverse reactions to the fetus or newborn. The ease of use, rapid onset, and rapid termination of action is a good option for labor analgesia. General anesthesia is rarely used. However, it can be used for an uncomplicated vaginal birth. It is chosen when rapid anesthesia is needed in an emergency childbirth situation or when a spinal epidural block is contraindicated. Major risks include difficulty with or inability to intubate or aspiration of gastric contents. If chosen to use, women will be NPO and IV infusion will be put into place, and pre-medicated if possible with an oral antacid, as well as a wedge being placed underneath the woman's hips to displace the uterus so it prevents compression of the aorta and vena cava. Types of anesthesia used are propofol, which is a short-acting barbiturate, and ketamine. The Selleck maneuver is a potential nurse intervention when pressure is placed on the woman's cricoid cartilage with the nurse's fingertips as the woman begins to lose consciousness to block the esophagus and prevent aspiration should the woman vomit or regurgitate. Nursing care. Nursing management is a combination of nursing expertise in maternity care knowledge and understanding of anatomy and physiology, medication and their therapeutic effects, adverse reactions, and methods of administration. Informed consent. Options are explored and discussed in the 3rd trimester neonatal visit. Women must be informed and clarified about all the adverse effects. Timing of administration. The woman must understand that systemic opioids are not administered until labor is well established.
Preparation of procedure will consist of explanation of positions for different administration of pharmacological measures, the degree of discomfort to expect, the expected time frame before the medication takes effect, informing the mother that long needles are used for pudendal nerve blocks, complete emptying of the bladder is needed for admission of the analgesic and anesthetic.
Administration medication via intravenous route. They are given slowly in small increments during contractions. The medication does not cross the placenta. Rapid onset of pain relief occurs via intramuscular route. Onset of pain relief is delayed, and a higher dose of medication is needed for effective pain reduction. Thanks for watching. Any questions?